please join me in welcoming to the Distinctive Voices podium, Dr. Sarah Jane Barber.
Thank you all. I am so excited to be here. I haven't had a chance to do a presentation on some of my work in quite a while. I think back in 2020 when we all went to virtual learning at most of the universities, I started teaching online, and I actually haven't been teaching in person since. So there's such a demand for the online classes. So it's really lovely to be back here with an audience who is actually going to be more responsive than when I'm just videotaping myself talking in my own office. So I'm thrilled to be able to talk about the research that I've been doing, that my lab has been doing. But before I actually get into what our lab does and what I do, I want to talk briefly about some significant demographic shifts that have been happening in many places around the world, although I'll talk specifically about what's going on here in the United States. So over the past century, we've seen a remarkable shift in what the society looks like in the United States. And when we're thinking about people 65 and older, we've actually seen an 1,000% increase over the last century in the number of people 65 and older. So to illustrate this more clearly, what I wanted to introduce you all to first were these population pyramids. So population pyramids show two key aspects of population structure. Is showing you age, so as you go up the pyramid, we're increasing in age. And it's divided between men and women. So the bigger the bar, the more people there are. And it typically has a pyramid shape. So the reason they're called population pyramids is because they look like pyramids. So traditionally what we see is that there's a lot of babies born, but not all babies make it to be children. Not all children survive to be adults. Not all adults survive to be older. So we have sort of this pyramid shape. So what I want to show you next is what the population pyramids have looked like in the United States, just from 1950 through 2020. And what you're going to notice pretty quickly is that in 1950, we really did have this pyramid structure in the United States. But as people are living longer and into old age, that's really shifted over time. So here we are in 1950. Here's the baby boom cohort that you can see sort of moving up the pyramid. And behind the baby boom cohort, there's other cohorts that are also kind of moving up. So it's really starting with the baby boom cohort, but then continuing after, people are living longer than ever before. And we really are no longer having this sort of pyramid shape in our society. So this is something that we have been seeing. The US population is older now than it's ever been in the past, but this is something that is also projected to continue into the future. So by the year 2030, which is hard to believe, just 5 years from now, all of the baby boom cohort will have aged into 65 and older. And at that point, we're expecting that about 1 in 5 Americans will be 65 and older. By 2035, which is only 10 years from now, again, hard to believe, we're expecting that we'll have more people aged 65 and older than 18 and younger. And this is unprecedented, that we would have more older people in our society than children in our society. So this aging of the population brings a lot of discussion that we could be having. So there's a lot of opportunities. There's a lot of great things about this. People are living longer and healthier than ever before. But there's also challenges that come with this as well, from public policy through every aspect of life. However, I'm trained as a cognitive psychologist, so I really think about cognition and memory. So when I think about an aging society, one of the things I think about from my own research standpoint is what this will look like in terms of memory and cognition for people as we're getting older. As you might know, it's not a great story necessarily. So I will hopefully suggest that this is not as bad as it looks at first. But when we do research studies, what we consistently find is that there are age-related declines in memory and cognition. And the specific trajectory looks different across different types of memory or cognitive function. Some have sort of stability into midlife and then declines. Others have more linear declines starting from age 20 onwards. But generally what we see is that there are some normative declines that happen with age. And to be clear, here I'm just talking about sort of healthy, normal aging. We're today not really going to be talking about diseases that affect cognition and memory like Alzheimer's disease or other forms of dementia. Now, when we see graphs like this, it's really tempting to think about this as just being related to brain function. We know that cognition is pretty tightly tied with brain function. And when we look at changes in the brain with age, we also see similar declines. So what I'm showing you here is a figure showing the hippocampus, which is a brain area that's really important for memory, particularly episodic memory, and looking at the volume of this brain region just across later adulthood, so from 60s through the 80s. And you can see that there is decreases in hippocampal volume across older adulthood. And we also know that aging, though, doesn't start at 60. I could have showed you other graphs. If we go back in time, we see also declines in hippocampal volume, even at earlier ages. So between 20 and 40, we can see some changes as well. So I think when you're thinking about these and you're looking at these two sort of graphs side by side, it's really tempting to say that the cognitive pattern I just showed you, where performance is declining with age, is due to the brain changing with age. But we also know that there's not a tight one-to-one coupling between these things. So some people show brain changes with age that look large, and yet their cognitive changes are not that large. Other people show large cognitive changes, and yet relatively smaller memory or brain changes. So what I'd like to argue today is that adopting a purely biological approach to the study of cognitive aging really overlooks the importance of other factors, and in particular social factors and societal beliefs about aging that are also contributing to some of these age differences that we're seeing in memory and performance. So today I'm going to be talking specifically about the work that my lab does on this topic, and we really study how negative expectations and stereotypes about aging can adversely affect people's performance, particularly in the memory domain as we get older. So what do people expect regarding aging? It's also not a good story. When we look at expectations about aging, they're largely negative. This is true not only in the United States, but sort of around the world. So these are some of the things that people say when they think about aging or when they think about older people. Forgetful, vulnerable, frail, slow, lonely, useless. And there are some good terms that come up. You might notice in very small font in the left-hand upper corner, there is the word wise. But by and large, the things that people are nominating when they think about aging are not overly positive. And this is true because there's a lot of these expectations that we have that are based on biological realities, some of them, although some of them not. But then we have these overly negative expectations that are driven from that. So in the prior word cloud, the term forgetful was right in the center. And as a cognitive psychologist, again, that's probably what I'll be focusing on most today. And while I did show you that there are changes in memory that happen with age, the expectation that many people have about what that looks like is not matching what we actually see in terms of the research studies. So just as a demonstration for this and preparing for this talk, I went to an artificial intelligence image generator, and I asked it to create a picture for me of an older person taking a memory test. And this is what it came up with. So I'll play it. He's just so frustrated, like can't do it. He even has his paper upside down. So this is sort of this idea that aging is bringing incompetence and complete inability to do things. And again, while there are changes in memory that happen with age, this is not it. So if we do a memory test and we ask people to try and remember a string of numbers and then repeat them back to us, on average, younger adults can do about 7. The range is about 5 to 9. If we bring in healthy older people and ask them to do that same task, the average is 6, and the range is about 4 to 8. So there is this decrease, but it's about by 1. And what we also are seeing is that the best older adults are doing better than the worst younger adults. So there's a lot of overlap also in terms of people's abilities. So the fact that there are these sort of normative changes that happen is really not what I'm talking about, and why I'm going to be talking about age stereotypes, not about age changes with memory. Because what I'm really... Yeah, of course. Is that better? So the expectations that that aging is sort of bringing this inevitable decrement in terms of just complete incompetence is what I'm interested in studying, and how that is impacting people's memory and performance as they get older. So there's a lot of different ways that we could go about studying this, and different scientists around the country study this different ways. In my lab, we study this by thinking about this idea of stereotype threat. Stereotype threat is an idea that was first introduced to the psychological literature by Claude Steele back in the 1990s. And it's this idea that when you are put in an evaluative performance situation, where you know that if you do badly, it will confirm something negative about yourself or a group that you belong to, it creates these concerns that you're going to inadvertently confirm that stereotype, and those concerns end up leading people to underperform compared to their potential. So this was first proposed as a way of explaining academic disparities between Black and white students. It's been since used, though, to explain lots of different groups performing in different evaluative contexts. It's often used to talk about why women are not going into math and hard sciences. But if you look at this definition, what you'll see is that there's nothing about this definition that says that this is an educational phenomenon or that it's a younger adult phenomenon. It really can happen anytime that somebody is in an evaluative performance situation where they know if they do badly, that it will confirm something negative about themselves. So my lab has really been studying this in terms of old age stereotypes and what happens when people know that they're being evaluated because of their age, and that they're being expected to maybe do badly because of their age, and how those concerns maybe will interfere with performance. So in order to study this in the lab, what we do is we bring people into our lab studies and we ask them to do tasks. And sometimes we just ask them to do the tasks without any specific instructions. We just give them a memory test, let's say. But other times we try to make them feel stereotype threat. Now, how do you make somebody feel threatened? It doesn't necessarily feel nice, but what we do is we bring people in, and if they're in our stereotype threat group, we say, we brought you in today because we're looking at age and memory. You're part of our older adult group, and we're going to be comparing your performance to younger adults in order to understand better how aging affects memory performance. Okay, here's the test. So that's our threat group, and we're comparing them to people who took the exact same test. We just didn't say that right before they took the test. So that's the approach that my lab group usually uses, is these very blatant, heavy-handed ways of making people feel this evaluative pressure about their age. But there are other labs that use other manipulations. So you can just tell people that you're looking at age and memory. It turns out that people know that the expectation is that age brings declines in memory. And there's at least one study that has tried to use a very subtle approach where they've just had the older participants show up, and they either go into a room where they take the memory test, or they go into a room where there's a younger adult also taking the memory test. And there again, the idea is that they realize that there's going to be a comparison made between them and this younger person. Now, when we do these types of manipulations and we look at performance right afterwards, what we find is that it usually interferes with people's ability to do well on the test that comes right afterwards. So this is sort of a prototypical example of what it looks like. So in this study, there was younger participants and older participants. The younger participants are in the white bars, and you can see that for them, it didn't really matter. So if you just tell them they're taking a memory test, or if you tell them you're taking a memory test because we're looking at aging and memory, that doesn't matter to them. They do basically exactly the same no matter what the instructions are. But for the older participants in this study who are in those gray bars, these instructions really matter. So the older participants who were told that the reason that they were taking the test is because we were looking at aging and memory decline, they did worse on the test that came right afterwards compared to the older adults that were not told that particular instruction. Within memory, we can also see that stereotype threat can interfere with people's ability to learn and get better with practice. So this is a recent study from my lab group where we were asking people to do what's called a two-back memory task. So during this task, participants are shown numbers on the screen, one at a time. And every time that a number shows up on the screen, your job is to say whether the number you're currently looking at is the same as the number that you saw 2 screens back. So you're having to constantly hold those numbers in mind and update them and make a decision. So right here, that second time you see the 3, you would say yes, because that's what you saw 2 screens previously. Now, in this particular study, we had participants come in, we had everybody do the two-back with no special instructions, so we kind of got a measure of what everybody was capable of doing. And then we had them do it one more time. In the control group, they just did it again. But in the stereotype threat group, they did the task once with no special instructions, and then we told them, actually, the reason we're doing this test is to see how memory affects, or age affects memory. Now you're gonna do it again. And then we looked to see how that affected their ability to do better on the task. Now, usually when we do tasks multiple times, people get better at them. So there's practice effects, so people get faster and their accuracy increases. What we see, though, is that when we introduce this stereotype threat, that practice effect really almost goes away. So people basically do the same in terms of accuracy, and while they get a tiny bit faster, they don't get that same benefit in terms of increased speed as compared to the participants who are in this control group. Now, I mostly study memory performance, although I have done some other outcomes as well that I'll be briefly talking about. But stereotypes about aging are not limited to the memory domain. And in research studies that have been done looking at these types of stereotype threat manipulations, we found that these types of instructions and manipulations can adversely affect lots of different outcomes for older people. So we see poor performance in terms of memory, but also in terms of physical performance, driving performance, ability to learn new technologies. And we've also seen things in the employment domain, so that people who feel a lot of stereotype threat in their workplace have less intentions to stay in their workplace, greater intentions to retire. They don't feel as connected with their coworkers. So these are very pervasive effects across lots of different types of domains. Okay, so now that I've sort of introduced you to this idea that of what stereotype threat is, this idea that it can interfere with performance, what I want to talk about with the rest of the time we have today are sort of three key questions. One is, why are these effects happening? So I know that when I introduce this stereotype threat instruction, I know people do worse right afterwards. But why? What is the mechanism that is leading to that impairment? The second question I want to talk about is, when and for whom do these effects occur? So are these effects occurring all the time? Or are there certain situations where we're more likely to see that a stereotype threat effect will actually interfere with performance than others? And then last, I'm going to circle back to the sort of bigger so what question. So outside of a science context where this is maybe an interesting phenomenon, what does this matter? And here we'll really sort of circle back to this idea of clinical implications and what does this mean for health contexts. Okay, so we'll start with this why question. So when people experience stereotype threat, why is this actually impairing their performance? So the stereotype threat literature is huge. There are hundreds and hundreds and hundreds of studies on stereotype threat broadly. Not all of those in older adults, but many just across different populations and groups. And if you look at the literature as a whole, you're going to see that there are a lot of explanations about why stereotype threat is impairing performance. Some people say that it's because when people are in these heightened threat situations, they feel anxious. Other people say, well, it's actually stress. It's not really anxiety, but it's like physiological stress, like cortisol. Other people say, no, actually, it's just that they're monitoring their task performance more, so that they're really sort of doing multiple things. So back in 2008, Schmader, Johnson, Forbes proposed this integrated task model of stereotype threat, where they basically said that stereotype threat's complicated and that all of these things are true. So when people encounter a threatening situation, it does increase anxiety, it does increase stress, it does increase task monitoring. And maybe more some of these for some people than others, but what that all of these things do together is that it reduces the amount of working memory or executive control resources that people have, which interferes with their ability to do the task. So let's say that you are in this type of a situation and you're feeling anxious. You might try and engage some type of emotion regulation processes to reduce that anxiety. But doing that is going to require some of your cognitive mental effort, and so then you have less cognitive mental effort available to do the task well. Same idea with task monitoring. If you are now trying to watch and make sure you're doing well in the task, you're using some of your mental effort to do that, and so not all of your mental effort can go towards doing the task well. So this is sort of a nice model that explains a lot of different things in the literature, but with older adults, it's had really mixed support. So thinking about something like anxiety, what we see is that stereotype threat effects are sometimes in older people mediated by anxiety, but not always. So there's some studies that find that basically everybody feels anxious when they're doing memory tests. It isn't specific just to the stereotype threat group. If stereotype threat is really working by reducing executive control or working memory resources, we should also find larger effects on tasks that really depend on working memory resources. And we sometimes see that, although again, not always. So there's sort of been mixed support for this, this explanation of stereotype threat when it comes to older people. So a lot of the work in my lab has been thinking about other reasons that stereotype threat might also be impacting performance. And what we've really been honing in on is this idea that there might also be a motivational component here. So before I talk about that, I'm going to back up one step and just talk about the motivation framework that we've been using, which is this idea of regulatory focus. So according to regulatory focus theory, people differ in how they pursue their goals. Some people pursue goals with a promotion focus, where they try to gain as many rewards as possible. They're trying to reach some aspirational end state. And other people pursue goals with more of a prevention focus, where they're trying to fulfill obligations, responsibilities, make sure that they're checking off all the boxes to still reach that maybe same goal, but they're just doing it in a different way. This theory also says that people differ dispositionally. You might be very promotion-focused most of the time, and maybe most of the time I'm prevention-focused. But people can also be shifted from one to the other depending on context. As an educator, I definitely see this with my students. So at the beginning of a semester, students tend to be very promotion-oriented. They want to learn all the things. They have these aspirational ideas of what they're going to get out of the class. I'm just now wrapping up the end of the semester, and that is not how my students are approaching the class anymore. They are now in a very prevention-oriented focus. The goal is the same, do well in the class. But now what they're really making sure is that they're fulfilling all the obligations, that they're checking the boxes, they're following the rules, because they still want to do well in the class, they're just approaching it a different way. So building on this, it's been proposed by myself and others that stereotype threat is maybe another type of situation that shifts people's motivational focus away from being promotion-focused and more towards being prevention-focused. That when you're in these situations where somebody expects you to do badly because of some identity of yours, that maybe you become very vigilant and cautious not to be that worst version of yourself that someone else expects you to be, and instead just try and do what you can to try and fulfill the responsibilities of the task that you're being asked to do. Now, I'm not going to go through all of the studies that we've done because I wanted to get to some of the more newer stuff that we've also been doing. But if stereotype threat is inducing this prevention focus, then within at least cognition, what we should see is that it's making people more risk-averse and more cautious, where they're really trying to make sure that they're just fulfilling all these obligations, not necessarily trying to be the best version of themselves that they can be. And my lab has consistently found evidence for this. So I've already told you that when we induce these stereotype threat instructions, people have fewer correct answers on memory tests. What I didn't tell you is that we also see that it reduces memory errors. People aren't making as many mistakes. They're not writing down things that are wrong. When we do a recognition test where you have to decide for each item, was this something that you saw earlier, yes or no? They're more cautious. They're less willing to say that they saw it earlier. They're more willing to say, no, actually, I think that's new. And more recently, we've been also looking at errors of omission, so just not answering. And what we find here is a similar pattern where when we induce these stereotype threat instructions, people are just not willing to answer. So it seems like they're really just getting very cautious about how they're approaching the task, and that does have the drawback that they're not getting as many things correct, but it maybe also comes with some small benefits that they're also not making quite as many mistakes because they're being cautious in how they're approaching the task. Now, I don't have any evidence on this yet, but where we're hoping to take this next is I think this is great news when it comes to intervention, because I think that what this suggests is that we could just teach people, don't be so cautious, like answer every question, even if you're not sure. And that should be something that can actually get people to not be showing these detriments. So when stereotype threat is happening, it's impairing performance often, at least especially in terms of these correct responses. My lab group shows that this is often because people are just being overly cautious in how they're answering the task and how they're approaching the task. What I want to talk about next is when is this actually happening? So I've been talking just broadly about doing these types of manipulations and finding these adverse effects, but is this happening on every test for every single person? When I was first thinking about this, I was really intrigued by this biopsychosocial model of threat and challenge that Blaskovich and colleagues have. And this model basically says that when people are in these performance situations where there's a motivated reason to do well, there's evaluative pressure, that people are making sort of two distinct evaluations. They're looking to see how hard is the task, and also, do I have the resources to do the task? And when people perceive the task as harder than what they are personally capable of doing, that is when you get these stereotype threat effects and performance declines. But if people feel like they can do the task, then they shouldn't show these same effects. So I was intrigued by this model for a long time, and I really wanted to test this within the context of aging, stereotypes, and cognition. But the stumbling block I kept running into is that I just know from experience running lots of people through memory tests that people think memory tests are hard. And it actually doesn't seem like it matters how well people do on them. They still think they're hard, and they don't like doing them. And tend to feel not confident doing the test. And that's actually just not older people. This is just people in general don't love doing memory tests. They don't like being in my experiments. So I wasn't entirely sure how to approach this question at first, but I eventually was talking about this with a colleague, Kate Hamill, who studies older or age-related changes in physical performance. And we realized that by moving into the physical domain, this was a nice way that we could actually manipulate difficulty much more easily. So in the study I'm about to talk about, we were looking to see whether these age evaluations that I use to induce feelings of threat have different effects depending on how hard the task is and whether people feel like they can do the task. So we had an easy and a hard walking task that I'll tell you about in a minute. And we had people that complete this task either under stereotype threat or not. We had about 160 older people that came into the study. And I just wanted to point out, these people that we picked were all pretty physically healthy. We had a whole slew of exclusion criteria to make sure that this was something people were physically capable of, even if they maybe don't feel confident doing it. So physically, they should be able to still do it. So the way that this experiment worked is we had everybody come into the lab. We had everybody just do a walking gait task. Gait is just another word for walking, just to see how people were walking, how fast they were walking, just as a baseline measure. And then we randomly assigned them to either this stereotype threat condition, or in this study, we actually tried to make people not feel threatened in the other condition. But in order to do that, we told them that we were comparing them to 90-year-olds, and that we were curious again about aging, but that they're now on the good end of this comparison. And then we asked them to walk again. And for half of our participants, we just had them do an easy walking task, and that was just walking. So we just asked them to walk back and forth at their own comfortable speed on this mat that I'll show you in a minute. However, in the difficult condition, we had them walk back and forth, but within a narrow base of support. So we had 2 tape-marked lines down on the walkway that were 15 centimeters apart. So it's essentially like being on a balance beam, but you're not up in the air. So you're on the ground, but walking like with your feet 1 foot in front of the other. And then after they did this, they gave us some evaluations of how hard they thought the task was and whether they felt competent doing the task. So this is sort of what the walkway looked like, and it was a special walkway. It's a Sino walkway that allows us to get measurements of every footprint that happens. So from this walkway, we're actually able to see how fast people are walking, because we can see the timing of when their feet hit the mat. And we can also see things like the variability in their walking. So how consistent are the steps from one to the next? Safe walking tends to be very consistent, where each foot hits right after another. When you have more variability from step to step, that's when fall risks increase as well. So what we found was that in the easy walking condition, when we just asked people walk back and forth, The stereotype threat instruction did not matter. So whether or not we told people that we were looking at them because they were old, we're looking at age declines, or we thought that they were on the good end of a comparison, it did not impact their performance at all. Those are the two bottom bars in the blue and the red. However, in our harder condition where they needed to keep their feet within the lines, it did have an effect, but only for the people who didn't feel confident doing the walking task. So for the people who had low confidence in their own physical abilities, the stereotype threat manipulation led to them walking slower and with more variability than it did in the no threat condition. In the hard condition too, where we had those lines down on the walkway, we could also look at mistakes that they were making by stepping out of the walkway instead of keeping their feet in. And here we found that, again, there was a stereotype threat effect where people were making more mistakes, but it was only for people who felt not confident in those physical abilities. So these stereotype threat effects are not happening all the time for everybody across every single task. So when we introduce this age evaluation, it is leading to this evaluative pressure, but that only interferes with people's performance if they are feeling like the task is too hard for their own ability to do well on this task. So thinking about all of this together, I think hopefully from a science perspective, you all find this interesting. But what I'd like to end with for the last couple of minutes I have is just also why does this matter in terms of outside of the lab? So I think first of all, the argument I've often made is I think this matters quite a bit because of the way that we often study aging at universities around the country. So if I'm wanting to study memory and aging, and I'm just a regular old faculty member at a university, the first thing I need to do is find some older participants. So I'm going to put up a flyer, and this is actually based on a real flyer I found that says, "Memory across the lifespan." Are you interested in how memory changes with age? Are you 60 to 80? Do you want to come study memory and aging? And this was actually the picture that these people had on their flyer, which shows like some type of gear brain, but like with the gears like drifting away from your head. So the messaging here is not great about what the expectation is about what the researchers are going to find. But let's say that you saw this flyer and you decided you're going to volunteer for this study. So they schedule a session for you. You show up at a university campus, and if it's most university campuses around the country, it is going to be just teeming with 20-year-olds, just everywhere you see, only 20-year-olds. And then you show up to my lab. This is actually my lab door that says Cognition and Aging Lab on the door. And you're greeted by a younger adult research assistant. Now, this is the way most research studies around the country are done when they're studying memory and aging. But this looks awfully similar to how we do a stereotype threat induction. We are making it very clear to people that they're being chosen because of their age, that we're looking at memory and aging, and that there's going to be an age comparison. I would argue that a lot of lab studies are overestimating the amount of decline that happens with aging because of how we actually do our studies. I haven't done this research myself, but I do know that there has been work where we have manipulated where people do the experiment, and older people who do an experiment on a university campus versus older people who do an experiment in the community center where they're tested by a peer of their own age, they do better at the community center than they do on our university campuses. So I think that in a lot of cases, our studies are just not well designed to be ideal situations for getting people's optimal performance. And this was actually what I originally led me to be even interested in these studies, is when I was doing studies that were not designed to introduce stereotype threat, I was blown away by how people talk about their memory, older people talk about their memory. I have an audio clip here that I'm not gonna try because it wasn't working well, but it's a clip of a man who was taking a memory test. It was not a stereotype threat study. And he says, "Well, I guess I should go home. I guess I have Alzheimer's disease." And these were the types of comments that I hear over and over and over, like, "Oh, I'm not going to do well on this. I'm too old. You should have tested me 20 years ago, 30 years ago." Spontaneous comments that people are often making when they're having their memory tested. So I would argue that in memory studies, just in general, we are often seeing these stereotype threat effects at work. What we have also seen in my lab and in other labs is that when we give people tests that are commonly used in doctors' offices, like brief cognitive status exams, we also get stereotype threat effects on these. So when we introduce a stereotype threat before people do the test, they do worse on the mini mental state exam, they do worse on the Montreal cognitive assessment. And in some cases, this increases the number of people who fall below diagnostic screening thresholds for follow-up on these same exams. That depends on where people start. So stereotype threat effects are small effects. But if you're starting at a 30 and you're being dropped to a 29 or a 28, that's fine. The threshold's usually 26. But if you're starting at a 27 and then you're experiencing threat and that's dropping you to a 26 or a 25, then you might have some problems. And this is problematic because we also know that many people, many older people say that they think that their healthcare provider has negative expectations about them because of their age. So in many clinical settings, I think that people are experiencing stereotype threat and it can be interfering with people's performance. This is an anecdote, so obviously not something that we can make strong conclusions about. But I did have a participant call me up a couple years ago now to basically tell me that this had happened to him. So he had found that in his medical chart, he had a note that said possible mild cognitive impairment. So it wasn't a diagnosis, it was just a note from the doctor to like kind of monitor something. And he was calling me because he had recently been in one of my studies and he thought he'd done fine. And so he was curious, like, did I think he had also not done well, or was this something strange that had maybe happened in the doctor's office? Now, normally I wouldn't have had a good answer for him because a lot of times we're just using tests that don't have standardized values, but he was lucky in the sense that the study he had done for us was one where we actually had a lot of standardized values for how people normally do on these tests. And so I looked at it, and his performance was on the lower end on some ends, but within still normal ranges. So not something I would have flagged as abnormal at all based on how he did in the lab. And when I was talking to him on the phone about this, he basically described to me the experience of stereotype threat at the clinic. So he had told me that he'd just had a milestone birthday and that he'd gone in for his annual physical exam, and for the first time in his life, he'd been given a cognitive screener at the doctor's office. And there wasn't a lot of explanation about why that was happening, and so he started thinking to himself, like, oh, I bet it's because I just turned, I think it was 70. And he made a mistake really early on in the exam. One of the first questions is often, what's the date? I couldn't tell you today what the date is, but he didn't know either. And then he started thinking about the fact, like, oh my gosh, I made a mistake, I don't know what the day is. And then he didn't hear well, and so he made a mistake on the repeating some words back, which would have probably happened anyways because he had a little bit of hearing impairment. But then he started perseverating on that and missed some questions. And then by the end of the exam, he said that he just didn't even know anymore, and so he sort of didn't answer because he just wasn't so sure. And altogether, this resulted in him scoring pretty badly on this cognitive screener and now sort of having a follow-up. Again, he wouldn't have gotten a full diagnosis, but it definitely did interfere with his life. He was keeping a detailed notes for himself, a journal of every time that he forgot, because he was trying to just make sure that he really wasn't having some bigger cognitive issues. So thinking about the clinical implications, what my lab has now been more recently doing is thinking about what happens when people also learn that they have increased risks for things like Alzheimer's disease. And we've been thinking about this mostly in terms of awareness of ApoE genotype. So the ApoE gene is our best known risk factor, genetic risk factor for late onset Alzheimer's disease. People have 2 copies of the gene, one from each parent, and there's 3 different versions of the gene. There's the E2, the E3, and the E4. So you could have like an E3 from your mom and an E3 from your dad. That would put you as an E3, E3. Or you could have an E2 from your mom and an E4 from your dad. You'd be an E2, E2, E4. But what we also know is that if you have a copy of the E4, it increases your risk for late onset Alzheimer's disease. And people who have the E4 copies, if they do develop Alzheimer's disease, also tend to have symptoms at an earlier age than people who don't have that. So this is, again, it's a risk factor gene. It's not an inevitability. There are people who get Alzheimer's disease that don't have this gene. There are people that have this gene that don't end up getting Alzheimer's disease, but it does increase risk. Now, it used to be the case that clinicians were really reticent to disclose this information to people because there's not a lot that you can do about Alzheimer's disease in terms of prevention. But people are finding out their ApoE genotype. So if you've ever taken a 23andMe kit or some other direct-to-consumer genetic kit, they often come with your health information, including your ApoE genotype. So people are finding this information out just at home, kind of without expecting to. However, it's also becoming more common to have this disclosed in clinical settings. So it's been thought to help identify people who are most at risk, guide preventative care. It's becoming more common to try and identify these people for Alzheimer's disease trials, clinical trials. And more recently, there's been some Alzheimer's drugs that have hit the market to try and slow symptom progression. But what we also know from these new medications is that the risk for side effects are higher for people that have the E4 allele. And so it's also being disclosed to these people because it's part of the risk-benefit conversation about whether they should be taking the drug. Now, early studies that were looking at the disclosure of ApoE genotype found that it was relatively safe. So safe in the sense that it didn't increase major depression or lead to suicidal ideation. However, that's not to say that there are no effects of disclosing this information. I don't know if anyone remembers this story from a year or so ago, but Chris Hemsworth, who's an actor, found out that he has 2 copies of the risk gene. So he has the highest possible risk of developing Alzheimer's later in life. And in response to finding out this information, he took a step back from acting and made some health-related changes in response. And this is consistent with what we see in research studies. So when people find out that they have this E4 risk gene, people do report trying to make health changes. They say they take more vitamins and they change their health insurance. But there are some smaller negative effects as well. So people also report greater concerns about discrimination, particularly from their health insurance companies. It also lowers confidence in memory abilities. And then there was one study by Lineweaver and colleagues that found that people who knew that they had the E4 gene also did worse on a verbal memory test. But there hasn't been that much research looking at these effects on cognition. So this is what our lab has been doing recently. This is not published yet, but we had almost 200 people that we recruited where we knew their genotype, and about half of them knew what their genotype was as well. And we had these people complete some objective memory measures. We had them tell us about what they thought about their own memory. And then we also had them do some stereotype threat measures as well to see whether this, knowing this information made them feel anxious because they knew this information. Now, when we looked at objective memory, I don't have a graph here because we didn't really find anything. So I think actually this is good news, is when we looked at sort of a more comprehensive battery of things, people who knew that they had this high-risk gene weren't really performing any different than people who didn't know that they had this high-risk gene. And in this population, we actually didn't even find any genotype effects. People who had the high-risk gene did pretty similarly to people who did not have the high-risk gene, because we were looking kind of 60s and early 70s. However, there were some effects in terms of how people felt about their memory. So people who knew that they had the high-risk gene said, I don't think it's worth trying to improve my memory. I think that it's useless to try. My memory's going to be what it's going to be. They also didn't feel like they could control their attention through effort. So there's sort of this belief that even if I try hard, I can't control my cognition. And that's surprising, because the people who had this same high-risk gene but didn't know they had it didn't have that same response. So it really was that the knowledge of having this gene that was making people feel like they didn't have as much control over their own cognition. We also found some beneficial effects for the people who found out that they had the low-risk gene, so people who found out, actually, I'm not at risk or higher risk. They were less likely to think that everyday memory lapses were signs that they were developing Alzheimer's. So they were less likely to say, when I forget something, I'm apt to think it's Alzheimer's, or I think I'm developing Alzheimer's now. They just felt a lot better about their current memory abilities. The other thing we did find, though, is that the people who had the high-risk gene, these E4 carriers, were more likely to report things consistent with feeling stereotype threat about the cognitive tests. So even though they didn't actually do worse on the cognitive tests, they were more likely to say things like, I found myself thinking about my genotype while I was doing the tests, and knowing my genotype makes me feel anxious about my memory abilities. Or when I forget something, I worry that it's because of my genotype. So even though it's not having these carryover effects in terms of actually impairing people's performance, it is introducing these sort of concerns and evaluative thoughts of like, oh, what if I am not going to be doing well because of what I know now about myself? So thinking about sort of take-homes, what I'd argue is that these stereotype threat effects are really important because I think that researchers need to be thinking about them when we're designing our research studies on memory and cognition. I told you at the very beginning I was going to show you that picture of the cognitive decline, but I don't think it's quite as bad as that graph depicts. I don't think it's as bad as that graph depicts. I think that some of that is overestimation based on how we do our studies. Clinically, though, I think that when people are feeling concerned about why they're being assessed and if they're being assessed because of their age, it can lead to these negative performance impairments. And that this might be something we really need to be thinking about more as disclosure of Alzheimer's risk information becomes more and more common as we're moving towards more personalized medicine and other changes that have been happening. So with that, I'm actually going to wrap up so I have time for some questions. And thank you all so much for your attention. And I'd be happy to answer any questions people might have.